So good evening, everybody, and welcome to this collaborative webinar between Sancheti Institute for Orthopedics and Rehabilitation and Occupational and Indian Association of Occupational Health. I'll hand it over to Dr. Neha now, and she can take us through the panel and the program. Over to you, Dr. Neha.
Yeah, thank you, sir. Good evening, all. I welcome all of you on behalf of Indian Association of Occupational Health, Pune region and Sancheti hospitals. Today we'll be having a webinar on OPD protocols for doctors in this COVID-19 phase and the occupational precautions for all the workers in all the industries. We have got two renowned speakers with us, Dr. Chetan Pradhan, who is orthosurgeon associated with Sancheti hospitals, and Dr. Shivan Maria. He's an orthosurgeon from UK. We are having a panel with us. Our national president, Dr. S.K. Raut, and Dr. Amit Kumar Kulkarni will be joining soon. So we are all eager to hear to you, Dr. Chetan Pradhan. So I'll just hand over to Dr. Ashok, and then we'll start the session. Thank you.
So we have a message from our chairman, Dr. Parag Sancheti, and he's unable to join, but he has sent us a message. I'll share again.
Good evening, friends. I'm Dr. Parag Sancheti, Chairman, Sancheti Hospital, Pune. It's indeed a great pleasure for me to announce this occupational health webinar, which is being organized on the behest of Sancheti Hospital and the Indian Association of Occupational Health, Pune. The topic for discussion today is the OPD protocols for doctors in COVID and occupational precautions for workers. I think this topic is very important because we have now achieved a new normal where we are following different OPD protocols than what we did before this corona pandemic, and definitely the occupational precautions changed a lot in this last 3 months. So for this today we have a very eminent panel. We have Dr. Neha Kulkarni, President of IOH Pune, along with Dr. Amit Kulkarni, Secretary of IOH Pune, and Dr. S.K. Raut, who is the National President of IOH. They will be sharing their views on the same topic. We have two eminent speakers, Dr. Chetan Pradhan from Sancheti Hospital, who is a leading trauma surgeon, and we have Dr. Shivan Maria from UK, who will also guide us on the different protocols which have now developed in this pandemic. I wish this occupational health webinar all the best, and I'm sure all the viewers will benefit and get a lot of value from this webinar. Best of luck.
So thank you very much, Parag sir, for that encouraging words. And let's begin the program, and I invite Dr. Chetan Pradhan to share his screen and start the proceedings. Over to you, Pradhan sir.
Thank you, Dr. Kulkarni, and thank you, Ashok, for giving me this opportunity to share a few guidelines on the COVID-19 protocols as far as OPD practice is concerned. Good evening to all the listeners. Let me start by saying that all these protocols or various points that we will be discussing are just suggestions. They are just guidelines from various sources like the Indian Orthopedic Association, the Center for Disease Control, USA, the IMA, the Ministry of Health and Family Welfare, India, the ICMR, etc., and a few scientific papers from the JBJS, Lancet, etc. Now, you must realize that this information is still evolving, it's still getting updated and changing almost every single day. And just to give you a rough statistics, we have about 50,000 papers on COVID and protocols and guidelines about COVID till date, and they keep on doubling almost every 2 weeks. So that's an enormous amount of literature that is coming up, and it just shows that we still are far from knowing a lot of things about this disease, and therefore the guidelines keep on evolving and changing. So what I will be talking is primarily what we do in Sancheti Institute and what are recommended guidelines the world over. And these are just suggestions. There's nothing legal about it. But then these are the suggestions which will help you to protect yourself, your staff, and your patients. Because from all the advisories, this seems to be the motto. Now, when we talk of occupational health, there are two sets of guidelines that we need to follow. One is for the workplace staff, the staff members or the workers in the company or the factories, and separate guidelines for healthcare professionals or doctors who are catering to these workers and the health and the staff of the company. One must need to remember that things are not the same anymore. We all need to slow down as doctors. And I like this quote by Ratan Tata, which was doing the WhatsApp rounds recently, that in today's world, the returns are bound to be slow. Let's accept it. It is not the time to count your profits on numbers, but to stay alive and safe is the profit. So we need to get adjusted to this new normal by changing our mindsets about practice. And this applies for the occupational health as well. Now, what do we mean by new normal? Now, there is a thing about getting the workplace ready for COVID-19 or compliance at workplace about COVID-19. Now, everywhere you must have heard that it is basically encouraging work from home. So unless it is absolutely necessary for that worker to be in the premise, try to encourage work from home. Anyone with even mild symptoms of the disease like fever, myalgia, or dry cough, any respiratory illness, advise him to stay at home and get tested for COVID, because early testing and early diagnosis is the key for successful treatment. Anyone from the containment zones should stay at home. Senior citizens must work from home. By senior citizens, I mean anybody who is beyond 60 years of age. So try to encourage this work from home technology, this concept. And if you go by the worldwide norms nowadays, it is going to be the new normal. Work from home is here to stay, and we need to adjust to it. So actively promote teleworking. Avoid, if that person has to come to the workplace, then in the company or office, avoid crowding, especially in areas like cafeterias, etc. You need to sanitize all the areas where there is crowding. So all the alleys, all the passages, especially the toilets, every 2 hourly. And this is mandatory. We must keep a timetable of who's doing what kind of sanitation throughout the premise. Travel restrictions, as far as possible, do not allow travel. Obviously, it's not allowed, at least till the lockdown exists. But then, if at all there is business-related travel, then the quarantine guidelines are for 1 week, and insist on COVID negative reports before joining, especially if that patient has traveled to COVID prevalent areas. The most important thing as far as workplace is concerned is sanitization. So you must have hand wash areas, preferably at the entrance itself. So a common area or multiple areas where the worker or the officer can come and wash the hands before entering the premise. Sanitizer kiosks or stations at regular intervals throughout the premise. And as healthcare workers, it is our duty to frequently train and brainwash every individual in the campus about basic precautions through various audiovisual aids. One of the aids that I liked very much at one of the workplaces is this, is to avoid men By men, I mean touching your mouth, eyes, and nose, and instead to follow women. So the full form of women is washing hands, social distancing, masking, exercising, and no unnecessary traveling. So various such attractive notice boards can be put up for patient education, and it is the duty of the healthcare worker to educate and create awareness. Another important thing is surfaces. So all the surfaces which come in contact with human beings must be wiped with disinfectants regularly. Which disinfectants? We are using 1% sodium hypochlorite. So commercially available sodium hypochlorite is freely available. Any alcohol-based disinfectant. We can insist on fumigation at night and ultraviolet sterilization at night. Now, quite a few supply companies are coming up with office ultraviolet sterilizers, or even large scale sterilizers using UV lighting in the night. So when there is no when the number of people are less on campus, you could use this, and there are quite human friendly ultraviolet lightings available which do not cause harm to the working patients. Healthcare, this was about the workers and the staffers in the company. What about us? What about the doctors and healthcare personnel in the industry? Now, there are certain responsibilities as doctors that we need to take care of as far as occupational health is concerned, and the primarily being preventing entry and spread of the disease on campus, diagnosing anybody who is suspected to have the symptoms, arranging transport of such a patient to a designated center. Most important, which is often forgotten, is documentation and records. So all patients entering the clinic have to be documented. A very detailed documentation of all meetings on the campus have to be kept, because if it comes to contact tracing later on, so if any of the member turns out positive, then one must have a mechanism where you can retrieve all the data as to who attended those meetings, and contact tracing should become possible. As I said before, regular educational briefings and awareness lectures by doctors is a norm, and it's needless to say that anybody turning positive must be kept confidential. Now let's start with the entrance to the clinic itself, and this is what we follow. So the first check, or the first level of surveillance must be at the security level itself, who must ask the history of why he is entering the OPD. He must insist on masking and hand sanitization. Try to accommodate only the patient and not the attendants, unless, of course, the patient is very unstable. And two things that the security must do is to record the temperature, record it using an infrared gun. I know that's not accurate, but still record it nevertheless, which can allow you to screen for fever and take some basic history like respiratory illnesses, or whether the patient is staying in a red zone area. Preferably keep a single entrance for the patient and a separate entrance for the healthcare staff. The second check post is where the triage is done, and that is after the entry. So this is where a healthcare personnel is available, like, for example, a sister or a brother who takes oxygen saturation. Now, pulse oximetry, portable pulse ox is available almost everywhere. So he takes a history of travel or occupation or cluster area, whether the patient stays in a containment zone, etc., and takes the oxygen saturation. He signs a COVID consent, because the person is entering a healthcare facility, and it is possible that he could be a patient, suspected patient, or he could be getting the infection from that facility itself. So a special COVID consent is required. Modified new scoring is where you triage the patient into a high risk, moderate, and mild risk group. If the patient has fever or any of the suspicions of COVID, then directly send the patient to a designated fever OPD. Now, one must have a designated fever OPD on campus where there is availability of level 3 PPEs, so the COVID suits, and facility to at least diagnose such patients. If the patient is asymptomatic, which will be the case most often, because if the patient is able to come for work, then he is probably asymptomatic. and then he is allowed to proceed to the clean zone, especially except if the patient is involved in emergency trauma. So if there is an industrial accident or trauma, then these checkposts are obviously bypassed. So if I can give you a diagrammatic representation of this, at the entry there is a first checkpost which takes the thermal temperature and a basic history, and this is a non-clean area where the patient's relatives or attendants are waiting. And then he goes to a fever OPD if he is febrile or suspected, or he goes to the standard OPD if he is asymptomatic. But if he is in an emergency, then these checkposts are bypassed and he straight away lands up in the casualty. Now, in the casualty, which will be rarely required in any industrial setting, the patient is assumed to be positive unless proved otherwise, and you need level 3 PPEs for all the staff there, like the shield, the masks, the gloves, etc. And then you must have arrangements to shift this patient to a designated COVID treatment center. If there is a COVID positive emergency, it requires a separate isolated pathway like isolated corridors, dedicated operation theaters, anesthesia, etc. So this is only possible to be treated in a designated COVID treatment center. One must realize that surgery on a COVID positive patient is fraught with multiple complications like pulmonary, ARDS, etc., and the mortality is higher than in non-COVID positive patients. So just to give you a brief, elective surgery must be delayed in these times when you have so many comorbidities, or if the age is more than 75, or if the patient is a suspected COVID positive patient, then you must wait for 2 weeks till the reports become negative. So you should not advise surgery on all these patients. Elective surgery I'm talking about, not emergency surgery. And this is the preoperative checklist that we routinely do for all patients undergoing surgery. So an RT-PCR ideally should be done for all patients. And if the patient is positive, then he's referred to a designated COVID treatment center. But as a screening test, we can do HRCT of the chest, do the CRP levels, D-dimer levels, and all these tests, which usually come high in a positive patient. Do a risk stratification by a physician and an anesthetist, and at the slightest doubt, the surgery is postponed for at least 2 weeks till the patient is negative. What are the tests that you do to diagnose COVID? It is the quantitative RT-PCR, which is the gold standard. It takes about 4 to 5 hours, so almost the whole day is gone in getting that report. Now the government is also promoting the rapid antigen test, which will give you the result within 1 hour, but it's not universally available. The TrueNat and the Gene Expert are also possible, but not, again, universally available. For community surveillance, what is being recommended by CMR is the rapid antibody test, which is the quantitative IgG and IgM. And as a screening tool, one can use the HRCT chest, which shows changes even in early stages. Realize that one has to take a swab right from the nasopharynx, so you should have a 6-inch long swab at least, and the test will become about 15 to 30% of these tests are negative if there is an error in collection or transport of the swabs. So if that happens and you're suspecting that the patient would be positive, then repeat this test after 72 hours if it is clinically suspected. Guidelines on PPEs, only those patients who are treating COVID positive, those doctors who are treating COVID positive patients require level 3 PPE, that is the COVID suits. But otherwise, level 2 PPEs, which mean just an N95 mask, a face shield, an impermeable gown, and gloves are good enough for all personnel who are doing office practice. So let's come to the OPDs. Like I said, the primary screening and triage should be done outside the OPD itself by the security, by a thermometer gun, pulse oximetry, and basic history. He should allow the patient to enter only after sanitizing the hands. So keep a foot-operated sanitizer at the entrance and disposable masks. Now, quite a few patients do not have disposable masks and they're using cloth masks, that is also fine, but it is good practice to keep disposable masks ready and give it to the patients who are entering your clinic. So ensure hand sanitization and ensure masking. The person who is doing this, so your security must wear a level 2 PP. So he should have a face shield and he should have an N95 mask. And he must keep a proper distance from himself and the patient. So this is what we do at the entrance. Then is your reception and registration. So again, preferably there should be a glass barrier here where the reception staff ensures normal oxygen saturation. So you do pulse oximetry here, as is being shown in this figure. The person also ensures that the patient is wearing the mask properly, and the personnel themselves are wearing level 2 PPEs. So masks, face shields, and gloves as a bare minimum. If glass barriers are not possible, then adequate distance should be kept, like you have in visa lines, etc. So if you see this, there is a marking on the floor where the patient stands, and adequate distance is kept between the receptionist and the patient. So this is how it should be, by marking the floor and keeping a good amount of distance from the personnel and the patient. The guidelines for reception, preferably see the OPDs by appointments only and give less appointments. So ideally not more than 6 to 8 appointments per hour. Ideally only one patient should be seen at a time, no attendance if the patient is stable. The patient must enter the clinic with a mask after sanitizing the hands. So gone are the days when you have had full OPDs, and this is not the way now. So give limited appointments, keep a gap of 10 minutes for disinfection after every patient, use patient calling screens or display boards like these so that there is no crowding. In the waiting area, maintain physical distancing, at least 4 feet from each patient. I already talked about glass or acrylic barricades between the staff and the patient. The staff manning your reception and the seating area must use a 3-layer mask, face shield, and gloves. In the waiting area, see to it that you have adequate areas for either hand wash or sanitizer bottles or sanitation kiosks and educational charts and videos. So this should be done as a mandatory. So you must have proper distancing, wide, well-ventilated waiting rooms, and keep sanitizers all over. Preferably no air conditioning, keep the windows open. As far as the main OPD is concerned, you must preferably have 2 rooms so that each one can be sanitized after every patient. Sanitize meaning at least the surfaces can be wiped using 1% hypochlorite solution. Preferably avoid AC. If you must use an AC, keep it to between 25 to 30 degrees and humidity at 40 to 70 degrees. Ensure that there is only one staff, both with N95 masks, shields, and impermeable plastic aprons. The examination surfaces where the patient lies should be preferably of resin so that they can be wiped with hypochlorite solution, or use disposable paper sheets which can be discarded after every patient. Clean with disinfectants after every single patient. Follow-up can be encouraged over telemedicine wherever possible. If the patient is suspected or known positive, then you must have arrangements to transport that patient to a designated COVID treatment center. The ambulance should not be a routine ambulance. There is a separate ambulance kept for that. And the ambulance has to be sanitized after the patient is transported. Now, this is just a protocol that we follow as far as treatment of patients are concerned. It's quite a busy slide. There's no need for you to, because I'm sure at the industrial clinic, we will not be having to treat the patients with or COVID positive patients, but this is what we have designed, or this is what is followed in designated COVID treatment centers. So this is for asymptomatic cases, mild cases, and this is for moderate cases. So remember at the end that personal protection equipment is your only savior, and therefore do not touch or see a patient without an N95 or a triple layered mask, a face shield, and gloves, because that's going to give you 90% protection. Remember, and educate your patients about SMS, which means sanitization, masks, and social distancing. However, with all this, let me end by saying that there's no need to be paranoid. Let's accept the new normal. Treat our patients, protect yourself, protect your staff, and the patients. Thank you very much and stay safe.
Thank you very much, sir, for that excellent talk. And I think we'll take questions at the end, and we'll request Dr. Shivan to share his screen and start presentation.
Sure, sir. Just 1 minute. Are you able to see my screen?
Yes.
Thank you. Good evening, everyone. I'm Dr. Shivan Maurya. I'm one of the spinal surgeons working in Salford Royal Hospital in Manchester. And these are some of the OPD protocols and the things that we've been following here in the UK. I think very important to note is what Dr. Pradhan said in the beginning as well, that guidelines regarding COVID are changing rapidly. The information is coming across very quickly, and every country is having to adapt their healthcare sector to the new normal. So COVID-19 was completely unexpected, and there was no country on earth which was prepared for this, whether it was in the West or in the East. And it's placed an unprecedented burden on doctors and healthcare workers across the world. In the UK, the effects of COVID-19 on healthcare have been broadly categorized into 4 categories. The first is the direct impact of COVID, which is patients with coronavirus who are falling sick and requiring healthcare, meaning oxygen or then ventilation. Then the impact of COVID on acute medicine, in which patients who are COVID negative are having medical emergencies, and they are now struggling to get to the hospitals or get the medical assistance that they need. We must not forget that there is also a significant effect on non-acute care. So people with chronic conditions who were regularly seeing doctors are now having limited access to healthcare as well. And lastly, one must not forget that this lockdown and social distancing has affected our lives significantly, which is having a significant effect on people's mental health as well. Now, there's a big difference in practice in healthcare in India versus the UK, and the systems are very different. But at the end of the day, we must remember that the principles in this pandemic are the same, which is we must protect our patients, we must protect the doctors and the staff, and we must make every effort to reduce the burden of COVID on the healthcare facilities. When COVID-19 had its outbreak in the UK and the country went into lockdown, the Royal College of Surgeons of England issued guidelines in the end of March regarding how surgeons should change their practice and adapt it in the presence of this pandemic. One of the things which was recommended was to switch to virtual outpatient clinics. So the Royal College of Surgeons recommended that where possible, surgeons and hospital teams should try to do outpatient clinics and connect with patients virtually to limit the number of people who are coming into hospital and getting potentially exposed to coronavirus. They went on to say that face-to-face review of patients should only be carried out if this is required based on clinical need, and ideally, if it has to be done, should be done just one single time. The General Medical Council, which is the UK's equivalent to the Medical Council of India, also issued guidelines for teleconsultation. And here, if we see this chart, it sums up what the General Medical Council says. It tells doctors that we must try to weigh up factors to decide if a remote consultation for a patient, which is either a teleconsultation or a virtual consultation, is possible and appropriate. And they've listed certain criteria which make it appropriate. You must have access to the patient's medical records. You should not need to clinically examine the patient on that visit. So we must clarify here that the virtual consultation is something which is being done in the interim period. And if the patient doesn't need to be seen immediately, they are then being told that they will be physically examined at a later date. We must have a safe system to prescribe medication to these patients. And we should have a way to give the patients all the information that they need about their treatment. Now, these are all critical if we need to try and do teleconsultations or virtual consultations for patients. They've gone to say that face-to-face consultations should be done in situations where the patient has complex clinical needs, or if you do not have access to the patient's medical records, or if you need to examine the patient. So these are situations in which they're saying that it is probably better if a face-to-face consultation is organized. However, if it is avoidable, then a virtual consultation should be done during this pandemic. If we think about teleconsultation, what are the advantages that it carries right now? The first and foremost is that it prevents the spread of infection. Obviously, hospitals in the NHS in the UK is where patients who are unwell with COVID are being admitted. Even though those patients are in wards and in critical care settings away from the outpatient department, it is almost impossible to limit staff and doctors to one part of the hospital and not to another part. So the way to stop the spread or to limit that spread in the community is to decrease the number of people coming to hospital in the first place. So that is the prime advantage of teleconsultation. Teleconsultation also allows us to triage patients and decide who needs to be seen and who does not need to be seen. Often there are patients who are old or immobile and they are not able to come to a hospital or a clinic very easily. And lastly, patients who are living very far from a healthcare facility also may find it difficult to get to the hospital, in which case a teleconsultation may be easier. While bearing this in mind, we have to accept that there are significant challenges of doing a teleconsultation. First of all, there is loss of visual clues. So as a doctor sitting in an OPD, when you see a patient walking in, many times you can tell when they walk in how the patient is. You can see if they are struggling with pain. You can tell what aids they need. Do they need a walking stick in their hand? So you lose that when you are doing a teleconsultation. We are unable to perform a physical examination. Right from medical school, we have been taught that physical examination is absolutely critical and key to diagnosing and managing patients. And obviously, it will not be able to perform this physical examination in a teleconsultation. It is also very difficult to build a doctor-patient relationship and trust when you are not sitting face-to-face with somebody. It is important to bear in mind that patient confidentiality has to be maintained, whichever route of teleconsultation you use. And one of the other challenges is prescribing medication, where documentation is absolutely crucial. Now, in the UK, the systems are very different, and usually doctors sitting in a hospital OPD clinic do not need to prescribe long-term medication because that is done by the general practitioner or the GP. Nowadays, the GPs are prescribing medications electronically, which can be collected by the patient directly from the pharmacy without having to necessarily consult the doctor. And these are situations in which patients have chronic conditions like diabetes, hypothyroidism. So the doctor calls the patient, speaks to them over the phone, reviews their symptoms. If they need to get tests done, those are done in a laboratory and electronically the results are sent to the doctor. After reviewing the results, the doctor can electronically prescribe whatever medication is required and the patient can collect these directly from the pharmacy. Now, this sort of a setup in India will be a challenge. So we have to see how to manage face-to-face visits. At present, in the UK, face-to-face visits are only by appointment. What patients go through when they come to the hospital, I think Dr. Pradhan has shown already in his slides, and I'm pleased to say that we are following exactly the same system here in the UK. In fact, in Sancheti Institute, they have shown that they've got 2 different levels of triage, which here we are not able to do in the UK. So what do we have here? We have separate entry and exits for patients and staff. Any patient who is coming into the hospital gets a temperature check, is asked a history of any COVID symptoms, is provided with a mask and hand sanitizer. Now, throughout their visit to the hospital, from the point of entry to the clinic, to the outpatient clinic, and out of the hospital, social distancing has to be maintained. Within the outpatient department, there are certain measures that we take to try and prevent any transmission of coronavirus from the patient to the doctor or vice versa. One of the big changes is that now doctors' offices where they sit and do documentation and paperwork after seeing a patient is separate from the examination room. So the doctor goes into the examination room with PPE on, examines the patient, speaks to them, and then goes to a separate room to do all of their paperwork. The PPE that we are provided for doing an outpatient clinic is a visor, surgical mask, plastic gown, and gloves. And we are told that we can wear surgical scrubs rather than our own clothes from home. The gown and the gloves that we are wearing is changed for each patient. The examination bed and area is cleaned between each patient that is seen, and that is with 0.1% sodium hypochlorite solution. Now, these are simple but effective measures, which I think once again, Pradhan sir has shown in his slides. Social distancing, maintaining this 6 feet distance. And the reason for that is that the droplets that are generated when a person is talking, if they contain coronavirus or not, we do not expect them to go beyond 6 feet. Obviously, if a patient coughs, this can be at a much larger distance, but in majority of the situation, in talking and simple conversation, that much distance gives a certain level of security. Wearing a face mask is absolutely crucial. And now anybody entering a hospital in the UK, doctors or staff or patients must have a face mask on. And here again, you can see a photograph in the clinic where signs are put on between chairs to try and maintain that 6 foot distance between patients in the waiting area. The NHS guidelines for PPE are demonstrated in these 2 photographs. What you can see on the left side is the lower level of PPE, which Dr. Pradhan described as the green, and in which the doctor wears a visor, wears a surgical mask, a plastic apron, and gloves. And this, on the other hand, is the full PPE, which has to be worn when you are dealing with patients on ventilators or those who are doing aerosol generating procedures. Those people get FFP3 masks, long sleeve disposable aprons, and they have to wear goggles as well. The aim of all of these measures is to try and flatten the curve. And by that, what we mean is that we want to try and decrease the spread of this disease in the community. And the main purpose of that is to reduce the burden on the healthcare facility. The main issue or the main limiting factor in tackling this disease when it gets very bad is that the number of ventilated and ICU beds in any country, in any part of the world is limited. And if suddenly a vast majority of the population requires access to those beds, they may not be available. Recently in the UK, you can see from this slide, the death rate has dropped significantly. And gradually the government here is opening out various things and allowing people to return to work while keeping precautions that I have already outlined above. Despite this and despite their best efforts, we can see instances and situations like this arise. There is a factory in Wales which has had 200 cases of coronavirus in the last few weeks after the lockdown was opened and they were allowed to resume work. So these are the sort of things that we must try to prevent. Thank you very much.
Thank you very much, Shivan. Dr. Neha, we can have the question answer sessions now. And if you have any questions, you can ask the panel for the answers. Go ahead, Dr. Neha.
She needs to unmute.
Yeah.
Dr. Raut, will you like to add something?
Dr. Raut, please unmute yourself. Yes, sir. Go ahead.
My question to Shivan Maria, he narrated few challenges while telemedicine. So then physical examination, then doctor-patient relations. There is one more thing I want to add to that is you cannot advise any investigation if patient doesn't come. And for that, patient has to come to the hospital. So if he needs some investigations, he has to visit the hospital. That is what I want to add.
Yes, sir, absolutely. You're right. If the patient needs an X-ray or imaging or a blood test, they may need to visit the hospital. And if that is the situation, then they have again created corridors whereby these people come into the hospital, have the investigation and leave with minimal contact with anybody else.
Yeah.
Can I add to that?
Oh, yeah, sure.
So if the patient needs an X-ray or lab, nowadays you have facilities where portable X-rays and lab collection at home is available and possible. What is difficult is clinical examination, and therefore what my take on this is your first consultation should be face-to-face. The follow-ups, all the follow-ups can be done on phone or on video consultation. But first consultation, which you need to clinically see the patient, should preferably be face-to-face, taking proper precautions. So you can actually reduce your follow-up OPD or your, just have a first consultation OPD, and the rest of the things can be done on teleconsultation.
Dr. Raut, will you please address?
Sorry?
Will you please address as a national president? Will you please say something?
See, now there are two things. One is treating patient, handling patient in hospital, taking care of the staff, nurses, mamas and maushis. This is the situation in the hospital where most of the people are sensitive and very cautious. But if you are conducting OPDs in corporate, at this situation, you must have a full support from the corporate, and the corporate heads should make certain strategies to follow into the factory and industries. Because there's a need to protect the workers as well as the medical officer in the OPDs, which is utmost important. So there are a lot of things involved as far as industry is concerned. That is, say, transport, entry at the gate, then following a social distancing of 6 meters at the working place. There are so many things which corporate along with the factory medical officer, they must make a stringent strategy where this infection should not spread among the workers. That is the most important. And once it is spread, no, so then that infection can be carried to the house, and the house family members will get infected. So that care has to be taken by the corporate people, and we need to have a great support from the corporate heads and occupier. That is what I wanted to add to the OPD in the corporate.
Okay, sir. So my one question to Dr. Shivan. What is the role of vitamin D in the treatment for COVID? Are you giving over there regular supplements, or does it really work?
Madam, so far there has not been any guidelines issued that we should be giving vitamin D routinely to patients. That being said, there is a lot of investigation here going on to why certain patients are dying from COVID or have died. And one of the big studies is into deaths amongst healthcare staff themselves. Now, over 200 doctors and healthcare staff working for the NHS have died in the UK. And what we have found is that majority of these patients are from the Black, Asian, or minority ethnic backgrounds, which is referred to as BAME. So one of the things proposed, one of the mechanisms proposed is a possible vitamin D deficiency. And they have said that that could potentially be one of the risk factors for mortality. But so far, there is no concrete evidence, and they are looking into this. One of the things that the NHS is doing to help decrease the risk to doctors who are Black, Asian, or minority ethnic is that we all have to fill out a risk questionnaire. And they look at other risk factors as well. Do we have other comorbidities like hypertension, diabetes, asthma, any other medical conditions related to clotting? And if any of the staff members have this, they are categorized into 3 risk categories. The low risk category is allowed to do all work and interact with COVID patients as necessary with the PPE on. The medium risk is allowed to do certain things, but not allowed to do aerosol generating procedures. And the high risk staff are not allowed to have any interaction with COVID positive or suspected COVID positive patients. So that is the general approach. But yes, one of the possible mechanisms linked is vitamin D deficiency. However, yet we are not prescribing medication for it.
Okay. Okay, thank you. Dr. Amit, do you have any queries? Dr. Amit Kumar?
Good evening, sir.
All listeners.
Good evening, sir. Good evening to everyone. Sir, my question is to Mr. Dr. Sivan, sir. Sir, what any other special precautions to be taken by doctor or paramedical staff at Tier 2 cities? Like our places are small places. So the patient scenario you might have known in India, the position what it has. So what extra precautions we can take?
Sorry, so this is in the case of an emergency. Sorry, I didn't understand. To paramedic staff, did you say?
Myself, doctors as well as paramedics.
I think, sir, the guidelines that Dr. Pradhan has outlined in his talk are the best. They are better than what we are even being able to do here. Having 2 levels of triage at the entry in the hospital, having the top level PPE, including N95 masks for all staff. These are the best measures that we can possibly do. One of the other things that we have tried to do in terms of staffing in the UK is to try and decrease the number of consecutive days that you are going into hospital or having a potential direct exposure. So one of the other mechanisms that has been proposed is that is contributing to severe illness is viral load. And if you are being exposed to many patients with the virus recurrently over a short span of time, you are potentially exposed to more load of the virus, which makes you at a higher risk of contracting the disease and getting a severe outcome. So to decrease that, what they try to do is that we work for 2-3 days, then we have 2-3 days off. And then we work for 2-3 days, and then we have 2-3 days off. And by doing that, you are spacing it out. But other than that, in terms of actual physical precautions, I think that what Pradhan sir has said and what is being done in Sancheti is the best that is being done anywhere.
Thank you, sir.
So, I mean, just to add to what Shivan said, what we can do in our level 2, tier 2 cities also is one is to reduce the number of people entering the campus itself. So you can space out the shifts in such a way that at any given point of time there's no crowding or there's not too many people is one. Second thing is a good triaging system where you take these body temperature, sanitize the hands, you wear masks, etc., distribute N95 masks to almost each and every worker itself. And second, as far as healthcare professionals are concerned, I think just 2-3 important precautions are to use a good N95 mask, your face shields, your gloves, which you frequently dispose of, and keep on sanitizing your hands over and over again. Reducing contact, physical contact with patients is what I think we should, whether it's tier 1 or 2 or 3 is mandatory.
Thank you, sir.
Do we have any more questions? Okay.
I just compliment both the speakers, Chetan Pradhan and Shivan Maria. It was a very informative and a nice lecture on this managing the COVID OPD. And Shivan Maria shared his experience at UK. This is the third webinar arranged by Pune branch, and I compliment to Pune branch also for arranging this webinar, third webinar on COVID during the COVID pandemic.
All right. So before we end, I'd like to show a video where we have detailed all the precautions that we are taking at Sancheti Hospital. So just a minute, I'll share again. Yeah. So this video contains all the precautions that we are taking at SIOR, and we can just go through it in a minute. So that was the video that detailed all the measures that we are taking. I'll hand it over to Dr. Neha to propose a vote of thanks, and then we can end the webinar. Dr. Neha, are you here? I think she got disconnected. Yeah, Dr. Amit?
Yeah.
Yeah, I think Dr. Neha got disconnected.
Yeah.
I'll hand it over to you to propose a vote of thanks, then we can end the webinar.
Thank you very much. On behalf of IOH Pune, I thank Dr. Shivan sir and Dr. Chetan sir for giving us a wonderful talk and giving us the way of management in OPDs. This is our third talk webinar in this area, in this lockdown period, but it was very informative, and we are thankful to Sancheti Hospital and their team for arranging this webinar. Thank you very much.
Thank you very much. Thanks, everybody. Thanks, IOH, for collaborating for this webinar. Thank you.
Thank you. Thank you.
Sure.